I invite now the three moderators from the various zones, Professor Lieutenant General P.P. Verma from Delhi, Santosh Varugis from Vellore, and Dr. Hemant Mehta from Mumbai. And we will together field, or rather ask Donald Molony questions regarding this new entrant, the new entrant on, or the new kid on the block. And we had to start off with two questions in the chat box. One was, how long should patients take sucroferric oxyhydroxide once it is started? I think you did mention one of the studies which switched over, but that we did not know what were the reasons. But would you advise it perpetually, or would you say take it for a short time and then switch to the more conventional phosphate binders?
So the clinical experience that's reported in the studies does speak to this question to some degree, because many of these patients that were switched were already showing inability to control phosphorus. Now, some of them are naive to phosphate binders, but many of them were not. So once one achieves a target phosphorus level with the good tolerance of the medication, I think it does not, it's not a benefit to the patient to try to switch them to something that they may now experience intolerance. There's no advantage to achieving a level and then going to another treatment where the success that you've already maintained, it may not be reiterated. The goal is to keep the phosphorus level well controlled forever. So the patients that I have on sucroferric oxyhydroxide in the US, and I have a fair number of them, I don't use any calcium-based phosphate binders, and I've switched a number from one of the others to this agent over the last number of years. I keep them on this agent. And again, one of the real advantages is that they really enjoy only having to take one per day. Again, I reiterate, they don't have to chew it to a pulp. There are some phosphate binders that you have to really chew very rigorously. You just have to break it. It doesn't have to even be done by chewing. It can be done by other means. And so it's very well tolerated. I keep my patients on it forever if they're successful.
That's great. Any of the other moderators had any other question which you?
Donald, wonderful talk. I enjoyed it and it was very clear. Just asking you that what percentage of your patients are on sucroferric oxide versus sevelamer?
Okay. I would say that it's about 50-50 for those who are on phosphate binders. I still have a substantial number who are on sevelamer carbonate because they've just been successful with that, especially those who are pretty good about diet and don't have to take. I've had some patients that have required 6 tablets per meal or 18 tablets per day plus 2 or 3 with snacks. So 20 tablets a day of sevelamer carbonate. Those are some of the first ones that I attempted to switch and have successfully switched them to much lower doses of sucroferric oxyhydroxide. Yes.
I just wanted to know, this drug is approved by FDA almost 8 years back. And even in European, it was approved almost 7 years back. And the drug is so good, all the benefits you have mentioned, why it has not become #1 drug?
Well, actually, it wasn't released in the US until it may have been FDA approved, but there was a marketing issue and releasing, so it's not quite 8 years, but I won't argue that it's been a long time. So I don't really know the answer to that, except habits die hard. And in the US, there is still about 30 to 40% of patients that are being treated with calcium carbonate. And the other thing is that phosphate binders are now in the quote unquote bundle, so that the dialysis providers have to basically pay for the phosphate binders. And sevelamer now is generic, and so it's a little less expensive. So there is an economic incentive for them to use sevelamer carbonate.
Santosh,
Maybe not a great answer, but it's a very interesting question.
Hi, two questions.
Yeah.
Professor, would you say that this drug is a specific drug of choice for those with difficult to control phosphate, or would it be just as similar to Sevelamer? That's first question. The second question is, do you have any experience of giving combination of phosphate binders with sucroferric oxyhydroxide plus Sevelamer, for example? Like sometimes we have to combine Sevelamer with calcium acetate. So that's our question. Thank you.
Okay, so I should not leave with you with the wrong impression. This is not simply for patients who are difficult to control, but I can tell you that in our clinical experience as this rolled out in the US, those were the first patients who were tried on this. So at this point, this is often one of my first line therapies, maybe my first line therapy for someone who's naive to phosphate binders. Many patients come to me with have been managed by someone else during CKD, and we still have our residents using Sevelamer in the hospital, and that's another limitation to spreading the good word here, so to speak. So it's not limited to people who are difficult to control, but that is what our initial experience was, because that's the people we choose to try to do something different. But now it's clearly also been demonstrated for us in our clinical experience to be very effective as a first-line treatment, as a monotherapy. There are people who use there's not a lot of studies on this. I actually did something with the Fresenius database looking at dual therapies, and the most common dual therapy in that database, and so we published this in Kidney 360, I think now 2 years ago, it's been a long time, was with Sevelamer carbonate. And so what was observed was that patients were on high doses of Sevelamer carbonate in excess of 3 to 4 pills with each 800 milligram tablets with each meal. And then they were added by their clinicians, the US form of sucroferric oxyhydroxide. And the result was twofold in this cohort. There was an observed improvement in the phosphorus control, substantial improvement in those getting under 5.5 milligrams per deciliter. And there was a reduction in the total number of pills. So they added the sucroferric oxyhydroxide. They did not stop the Sevelamer, but they were able to reduce the dose of Sevelamer carbonate substantially. Now, one of the questions that always comes up, and if you do that, is do you give them both together, put them in a handful, and everyone swallows at the same time as they start their meal? And no one knows the answer to that question. Generally, if I have a patient that is, for some reason, on that strategy, I'll advise them to take one at the start of the meal and then one at the conclusion of the meal, so that there's no science to that. So however it's given, I think that's what the experience shows.
There are a couple of questions in the chat box, both pertaining to the iron metabolism. So one asks whether is there any meaningful effect of SFOH on iron metabolism? That's one. I think you already did mention in your presentation that there isn't anything significant which gets absorbed.
Right.
But there's another, when I use the word significant, there's a question which comes up again in the chat box. Is there any problem if we give this drug to patients with normal target hemoglobin who have got an iron overload? So you've got hyperphosphatemia, normal hemoglobin, and have got the iron parameters on the higher side.
Yeah, so that's an interesting question. There is not a lot of evidence on that specific subpopulation. There is clearly the clinical trials, and I didn't show you all the early clinical trials, demonstrate clearly that there is very little iron absorbed over long periods of time from this medication. And that was one of the design efforts that was made in designing it in the first place. There is also some people have suggested that the evidence might support the notion that if you are clearly iron overloaded, there may be a reduction actually in iron absorption with this medication or with any other medication as well. So I think that the bulk of the evidence would support the notion that this is not going to be a problem with iron overload in patients. If you live in a litigious environment like we do in the US, you might say, well, maybe I'm going to avoid all iron products in that unique population. I wouldn't argue against that, but there's no evidence to support the notion that this will be a problem in that patient population.
That's good. And another question in the chat box is, there are reported interactions with levothyroxine, doxycycline, and cephalexin, which have been mentioned. So what is your take on this?
So I think that what is not generally appreciated is that probably all phosphate binders have interactions with drugs and bind some of them. It's been well studied in the newest agents that are now coming out, the two new iron agents. To look at that, the FDA required that they look at these. And in those patients, I think one has to consider a strategy to have the medications, those potentially interfered with medications taken at a time that is a number of hours separate from the original recommendation was 4 hours. I think 2 to 4 hours would probably be adequate to still maintain your doses. But if you have someone on levothyroxine, for instance, and they're on a stable dose of SFOH, then you could check their levels and make sure that you don't have to change it. I think that's still doable. But I would probably administer the levothyroxine at least 2 hours after the administration of the binder.
There's one more question in the chat box. If the loose motions are of a moderate degree and forces the stoppage of the drug, whether we can re-challenge once it settles.
Yeah, so people, that has not been reported in the studies that I showed you, but in experience, people have tried that and have had some success. My own take is that if I'm having a problem, I will give a holiday, so to speak, and then I'll re-challenge with a slightly lower starting dose. So instead of 3 tablets a day, 500, I might do 1 tablet with 2 of the largest meals, so 1,000. And I've had some anecdotal experience. You can take that from whence it comes. It's just a limited experience, so I haven't reported on it. I haven't actually tracked it, but the people are trying that. So I don't think it's unreasonable, especially if it's moderate or mild diarrhea.
We have another question of your phosphate binder polytherapy. How frequently is it required and what would be the combination?
How frequently is combination therapy required?
Yeah.
I don't know the data on frequency. I know that it is not that common in the US. So if you look at, again, these large databases of prescription pharmacies, it's probably far less than 20% of patients are in combination therapy. I would, and even less than that. So it is not that common. You still monitor in the same fashion in terms of side effects and effectiveness in lowering phosphorus. My suspicion is that for many of your patients who eat more of a vegetable-based diet, there's a little less of a phosphorus burden. And so you might be able to achieve with monotherapy, and you probably don't need to think about combination therapy as frequently. But it could occur. I mean, it doesn't occur very commonly, even in the high meat intake diet of North America.
Yeah, there's, I think we're just going to have to learn. Yes, Hemant?
Yeah. Donald, one question from me. We have several occasions when we have not only high phosphorus, but low calcium. At that point of time, what would you recommend? Just treat phosphorus with SFO and hope that calcium will come up as phosphorus come down, or combine it with a calcium-based phosphate binder also, or just give SFO with active vitamin D? What would be your choice?
Yeah, I would take the last choice because as long as, in clinical studies that have looked at this, when you give oral calcium to these patients, it doesn't improve your serum calcium level much. It's very marginal. It does go to calcify soft tissues. So I still avoid that. If it's really low, that's a problem, and you scratch your head and you try to get around that. If they're asymptomatic, it buys us some time. I would guarantee, however, that they have at least 600 to 800 milligrams of calcium in their diet per day. And there are many people who might not, and if they're largely vegetarian and they avoid milk products, they may not. So in that case, you could give a little bit of calcium, but I wouldn't use it as a phosphate binder. But clearly, I would exploit vitamin D, and I would try to lower the serum phosphorus level as much as possible.
And at what level of CKD?
We have to, we'll have to wind up.
Okay.
Okay, I just got I'm using my prerogative as the program director to ask this last question of Donald. Why is sucroferric oxyhydroxide not used in the non-dialysis CKD patient?
Well, it's not used in the non-dialysis CKD patients because the FDA in the United States, at least in our environment, it probably should be considered in that, and that there are some good clinical trials evidence to support the notion that it would be beneficial to try to correct this problem earlier on. But in the US, the FDA has not approved any phosphate binders in the CKD period because they're not convinced yet that there's enough evidence to support their non-renal effects, such as cardiovascular, in the CKD population. That needs to change. I think there's clear evidence that it's beneficial, but it's a problem. I do prescribe these in the CKD period off-label, so to speak, and I'm not supposed to speak about anything off-label, but it is my choice as a clinician to use these agents if they're FDA approved for any indication. And so I will potentially use that, but the FDA has not approved them for CKD, none of the phosphate binders, in fact.
Has there been any trials on in this group?
I do believe that there is an ongoing trial right now, but I'm not sure of that. I'm not involved in that particular trial.
Great. Donald, it's been wonderful hearing from you. And whereas we are heading to bed, you're getting up for an active day ahead. It's great to hear from you. And I know that you would have loved to have been here amongst us, but at least in the spirit, we are together. So all the best to you, and thank you very much for your excellent.
Thank you. I look forward to when I can visit personally. I have been to India many times, and I always love to travel to various places in India. So there's an opportunity. I'd love to come meet with some of you directly and talk about these issues and the broader spectrum. Again, thank you very much.
Thank you very much.